Well, welcome to our rounds today. Today's topics are a little bit different. We really wanted to essentially bring back some of the data and some of the information, some of the things we're learning with the data that's been collected, and give you two presentations. One from Adam Boisonneau regarding the heterotopic ossification sub-study that a lot of the sites were involved in. And recently submitted data, and I know there's a little bit of data still outstanding, but the
How's it going? Can everyone hear me?
Oh, there's Lucas. Yeah. 1 second, Lucas. I was just saying the vast majority of data from Adam is in, and then Nathan O'Hara is going to give us a little presentation as well on something called instrumental variable analysis, and I think a lot of you guys will find this interesting because I think he's going to show us how he may be using it in our data. But this type of analysis can be used for all sorts of other research questions. And I'm also on call today, so I think Lucas is going to help moderate some of the questions and stuff as we go through. So without further ado, Lucas, thanks for joining us. And Nathan, you want to take it away?
I'm not sure if, as Jared mentioned, many people have seen instrumental variable analysis before or used instrumental variable analysis. I don't know if there's any way to poll the audience, so I'll assume that this is probably a new topic for many people. So as a bit of a background, right, for a lot of our clinical research questions, we actually are trying to figure out cause and effect, right? These are causal questions that we want to ask, or sometimes they're called what if questions, right? What if the patient had received ChloraPrep instead of DuraPrep for their preoperative antiseptic? What if the patient received aspirin instead of low molecular weight heparin for their VTE prevention? What if a patient received total hip arthroplasty instead of hemiarthroplasty for their hip fracture? Would their outcome be different? Right? This is really what we're trying to do through these large trials. And why do we do it through these large trials? It's largely because we're afraid of bias, right? There's bias in things that we can measure, differences that we can see between the patients and that receive one treatment versus the other. But we're even more concerned about the bias that we can't measure, we weren't able to measure, between these two treatment groups, and the specific type of bias that they call confounding, right? Bias that affects both who gets the treatment and who gets the outcome. This is a big concern. And so that's why we love randomized controlled trials, right? It's seen as the gold standard. This simple process of randomization at a large enough scale, if you randomize enough people, what you're doing is you're removing both the measured and unmeasured confounding between the two treatment groups. And so the individuals, whether a patient is randomized to treatment A or treatment B, if you randomize enough people, we start to see them as being exchangeable between these two groups. You're starting to balance all these measured and unmeasured confounders that may exist and influence both who gets treatment and who gets the outcome. And this is really important if you want to start estimating causal effects, which is ultimately the goal for a lot of the clinical research that we do. A more cynical view on randomized controlled trials is it's called the gold standard because they're very expensive to conduct. Right? It's millions of dollars that go into designing and conducting. So patients receive a number of different interventions that are not randomly assigned. So think within the PREPA trials, right? So we're randomizing the preoperative antiseptics, but there's a lot of other co-interventions that individuals get. Some individuals are getting intrawound vancomycin powder. There's different antibiotic prophylactic regimens that different people are given by their surgeon, which at the discretion of the clinicians that are treating them. But sometimes there's random variation that is strongly correlated with these different treatments. What do I mean by that? Well, here's an example. A former fellow, Kanu Ukiki, former fellow at Shock Trauma, recently published a paper in JAMA where they asked the causal question. What if a hip fracture patient was treated with cemented hemiarthroplasty instead of uncemented hemiarthroplasty? Would their outcomes for revision have been different? And the clever aspect of the design in this study was they realized that surgeons have a really strong preference for one of these two treatments. Some surgeons really strongly prefer the cemented hemiarthroplasty. Other surgeons really strongly prefer the uncemented hemiarthroplasty. And this plot shows that polarization within preferences. So at a certain volume, they stratified their sample into essentially 3 different levels. Surgeons that had a strong preference, surgeons that did not have routinely strong preference for cement, strong preference for uncement, and then the middle ground of no strong preference. And it took just the patients that were treated by surgeons in either one of these two strong preference camps, whether it was a strong preference for cement or non-cemented or uncemented hemiarthroplasty, and use that data as what we would call an instrumental variable to look at the causal effect of one of those two different treatments on this outcome of aseptic revision, and found that the uncemented fixation was associated with higher risk of aseptic revision. So to explain what they're actually doing in this analysis, is a simple diagram here. So what we care about is the treatment. We care about the T, the treatment on some outcome Y. That's the causal effect that we're interested in. But in observational data, we have this U, the unmeasured confounding. Sometimes we can measure the confounding and then adjust for it, but our big concern is this unmeasured confounding. But by using an instrumental variable that strongly affects whether or not the patient receives a treatment or not, we can combine all of this information and start to estimate a causal effect. Now, there are a bunch of different examples of instruments. The provider preference, which Kanu used in his study, is a very common one, and common in the sense that instrumental variables are seen as a bit of a unicorn. They're hard to find, but if you're going to find one, provider preference often is one element or one instrumental variable that people use. Another one is the distance from a specialty provider. So sometimes they can use the patient's home address proximity to a specialty care provider. If you have difference in services offered between different hospitals, patients are more likely to go to hospitals nearby them. That one can be a bit trickier because where you live is often strongly correlated with a bunch of socioeconomic things that may bias those estimates. And so that tends to be less common. And another kind of trendy approach these days is using genetic variation. And we've tried to think about that within the fracture population. And I don't know if there's a great fracture question that can be predict who gets the treatment and who doesn't get the treatment. If your instrumental variable, the surgeon preference for uncemented versus cemented arthroplasty, if the surgeons don't have a strong preference and they go back and forth between the two different treatments, you're not going to have a strong prediction and not going to have a strong instrumental variable. So that's the first key element. The second key assumption that you have to make is that the surgeon preference for cemented versus uncemented hemiarthroplasty isn't affecting your outcome through some other pathway, that all your surgeons that like using the cemented hemiarthroplasty also use some other particular intervention that is not used by the other type of surgeons. And then you can't disentangle whether or not it's the cement versus uncemented hemiarthroplasty that's affecting your outcome, or if it's some other variable that's also really strongly correlated with this instrument that you've created. The second one is you don't want this confounding, additional confounding on your instrumental variable. I mentioned sometimes people will use the patient's proximity to a specialty hospital. That's sometimes confounded. Where you live is sometimes confounded by other social economic circumstances. So that's one concern with using that type of analysis, an instrumental variable. For using surgeon preference, I think you largely avoid this concern, this no confounding between your instrumental variable and Y, because in a large trauma center where you have a number of different surgeons, your assignment to surgeon tends to be a somewhat random process. It depends on when you're injured as to who's on call at that time, ends up being your surgeon. So if you have variation in surgeon preferences between a practice, then you kind of meet this assumption. And as Gerard mentioned, so one of the purposes of this talk at this time is that we'd like to use the PREPA data to start doing some of these instrumental variable analysis. And the first one in particular that we're looking at is the use of intra-wound vancomycin powder. So a number of the people on this call were involved in the VANCO trial, which is recently published, and that asked the causal question: does intra-wound vancomycin powder prevent surgical site infections? And it found a huge effect. It was a large randomized controlled trial, about 1,000 patients, and found a 35% risk reduction in patients that were treated with intra-wound vancomycin powder. One criticism might be that it was in a small subset of patients. The trial only included patients that had either a tibial pilon or plateau fracture. I think this practice has been now largely expanded to a number of different patients that were not included in this trial. So the PREPA data gives us a good opportunity to see if these findings are generalizable to a larger fracture audience. We've looked at the PREPA data that we have to date, and we see this nice polarization occur similar to what Kanu demonstrated in his JAMA publication. So, there's this green group of surgeons in the middle that kind of volley back and forth between using Benko and not using Benko. But you do have also a nice distribution. This is for surgeons that have treated more than 10 patients within the PREPA data set. So you have 15 surgeons from a variety of different centers that strongly prefer using intrawound vancomycin powder. And then you have also a fairly large proportion of the surgeons that rarely ever use it. And so this suggests that we do have a strong instrument here that meets a lot of the assumptions that we'd like to apply to answer this question. Obviously, once the PREPA trial is finished and we have this infection outcome, because that's really the outcome that we're interested in, again, for this research question. I'm happy to answer any questions about that specific design and the assumptions that we're planning to make with that. But before I ended, I also wanted to mention another application for instrumental variables within randomized controlled trials. So often randomized controlled trials will be analyzed using an intention to treat analysis. So whatever group that a patient is randomized to, that's the group that you analyze them in. There are certain situations where adherence is not great. You get randomized to aspirin versus Lovenox, but it doesn't necessarily mean that the patient's going to be adherent to that and take that medication. And it's interesting when you look into other fields. So in economics, they do far less randomized control trials, but when they do a randomized control trial, they really want to understand the causal effects. And often with those research questions, the compliance with your treatment allocation is not very good. And so the overwhelming majority of that field will actually analyze their randomized control trials using an instrumental variable analysis. So what you're doing in that analysis is what's demonstrated in this graph here. So the randomization process is your instrumental variable. You're randomizing patients to receive treatment A or treatment B. If they take that treatment or not becomes your treatment, the T. And so what you do in this analysis is you take your instrumental variable, which is your intention to treat analysis, and you essentially divide it by what they call your encouragement effect. You discount it for the fact that there's not perfect adherence on your treatment. And that allows you to estimate the causal effects within a randomized control trial where you observe poor adherence. If you have high or near perfect adherence, then your analysis will be the same. You essentially have no encouragement effect. And so then your ITT analysis is essentially your causal analysis. But just to present this to a group is another consideration if you're involved in a study that does have poor adherence to a treatment.
Hey, Nathan,
Yeah.
Just while you're on this slide, I've been gathering up a couple of questions, but before you move on, I think it would be pertinent to ask the question I have now while you're on this slide. Can you talk to us a little bit more about encouragement effect, how that's like, what is that number and how is it determined?
Sure. So to do this analysis, you actually do two different regression.
If no one else does, I'll jump in. I have a couple questions just that came up while you're going through that, Nathan. So when you're doing this instrumented variable analysis, the examples you showed, the example you showed that seems most pertinent to us in orthopedics, and particularly orthopedic trauma, would be using surgeon preference. Does there have to be a 50-50 split or close to a 50-50 split in surgeon preference? Because that's what it looked like at the hemiarthroplasty cemented versus uncemented study. Or is it okay if most of the surgeons prefer one treatment as opposed to the other?
Yeah, you don't need balance. You don't need that 50-50 split. You just need some critical mass, which is determined by your power analysis, sample size calculations. You just need enough surgeons that treat enough patients with some strong preference, and then another group of surgeons that have strong preference for the alternative treatment that you're comparing it to. But it doesn't have to be a 50-50 split. And in fact, with the Vanco example within the PREPA data, we don't expect a 50-50 split. It's the minority of surgeons that strongly prefer it, but there's, thankfully, with a 10,000 patient trial, it still gives us enough of a sample in that group to do this analysis.
And I'm happy to keep going if other people have questions, jump in, but otherwise I'll just pepper Nathan for my own knowledge. What areas has the instrumented variables most been used in? It sounds like the most kind of, I would say, quote unquote, famous or hot example right now is that hemi versus cemented versus uncemented hemiarthroplasty example. Are there other orthopedic examples people can read just to sort of familiarize themselves with this technique? Or is there another field of medicine or social sciences that would be worth looking into just to get examples of where it's used and how it can be applied to studies?
Yeah, that's a great question. So yeah, I think there's only one other total hip arthroplasty instrumental variable analysis that I saw in the literature. Has been very rarely applied to orthopedic research, and even quite rare in clinical research in general. It comes from economics and social sciences, is where a lot of these techniques were really created in the 80s, 90s is kind of when it a lot of the techniques were really developed, but it's been slow to move into clinical research just because it is hard to find these variables that meet these assumptions. I think there's probably more applicability to surgical research though, because surgeons do have strong preferences for different things, and once they develop a strong preference, tend to be pretty consistent in their application of that preference to their patients. And so I think it's a valuable technique, and it's something we can apply more, but I would say to date it has not been used very much. There's a really good paper, a review paper that I can put in the chat box afterwards if people want to read more, that just goes through a bunch of different that looks at clinical research examples and how it was applied, and it also has the math behind it if people are interested.
Yeah, thanks. I'd love to see that. Less interested in the math, obviously, mostly interested in the clinical examples. It would seem, however, just like you mentioned, that this is the perfect tool to apply to clinical research, because I would say surgeons are notorious for having strong preference with no data to support it, right? Like that's what we do. So this, yeah, it will be cool to see how this is sort of used moving forward, and if we can find a couple ways to make it work for us on some secondary analysis of the Prep-It stuff. So awesome. If no one else has questions, we can move on, but thanks a lot, Nathan. That was great.
Can I ask
My
just one
pleasure.
quick
Yeah,
question?
Diane, did you have a
Sorry.
question?
Yeah, just, you had said something about, the surgeon preference, and, within these larger centers, you're kind of getting randomly, it's almost like a randomly assigned of which surgeon you're going to get. So you're not concerned about, certain surgeons with certain preferences only getting certain types of patients, correct?
Correct.
What you had said. Is there concern that the problem with that would be is that within a hospital you might have a clustering of that preference. So the people who are in that particular site have in a similar setting have similar preferences, whereas somebody at a different site that might have a different type of patient population would have the opposite preference for whatever it is you're talking about, the Vanco powder or whatever. And would that be more of a concern that then, yeah, patients are getting, or sort of surgeons with a certain preference are getting one type of patient, and surgeons with another preference are getting a different type of patient just because of geography?
Yeah, exactly. Yeah, and I think all those concerns are are limitations on applying this methodology, right? There are some very strong assumptions, and it does have to be somewhat close to a random assignment. And as you mentioned, there's a number of scenarios where that might not be the case and violates those assumptions, and that does provide a limitation for this analysis.
I guess within Prep-It, it would be easy to look at, right? If you're looking at the people who preferred, what site they're at, right? So you could look for that sort of thing, but that would be I think something we would want to look at for sure.
Yeah,
because we know the patient population differs between the sites. So
yeah, I completely agree.
Perfect. Thanks, Nathan.
My pleasure.
And then there's a question in the chat box, Nathan. How would you determine the validity of an instrument variable in a big trial like this?
Yeah, so typically you would just go through these different assumptions, and you can attest a number of them. So the first main assumption, is it a strong instrument? You can test it and typically use an F test to test it. And there's different thresholds. A lot of the literature said it needs to have an F value of 10 or more. Now people are saying it should be over 100. But just looking at the data for that specific Vanco question, and the preference is very strong. And so we meet the assumptions on that strong instrument. So you can test that one, and some of the other assumptions you can test as well. So you kind of go through the different assumptions and then test to make sure that the thing that you're planning to use as an instrument actually meets these assumptions that you need.
I just wanted to make one comment that, clearly Nathan's probably one of the only people that has thought this much about this on this entire call. And so you may wonder, why the hell did we have this presentation that only Nathan can understand? But hopefully he has shown everybody this new technique, and just also the way that we want to continue to try and exploit our data. Obviously, we're going to answer one main question through an RCT, but all these other secondary questions that we're potentially going to ask, we want to be able to do it at the highest rigor. And this is one of the sort of more emerging techniques that has got a lot of good positive things about it. For all the coordinators and patients and people that are on the line, the other reason I wanted us to show this was that you may notice that some of your surgeons or colleagues have very strong preferences, and you may have heard that other people do it a different way. And this is, when you see those, these may be opportunities for other secondary questions, because again, as Nathan indicated, we want to, one of the cruxes of this model is to essentially leverage the fact that certain surgeons are going to have very strong preferences. So again, Nathan and Lucas, thanks for taking us through that a little bit and exposing us to this new method.
We okay to move on? Everybody think?
Yeah, I think let's go ahead and move on to the next presentation. Adam, go for it.
Perfect. So I'm going to talk about one of our sub-studies, which is looking at HO prophylaxis after acetabular surgery. And I guess first, just to thank you, David, for organizing all of this and inviting me to speak. And then thank you to all the participating sites and Prepare. I mean, everybody did just a phenomenal job in collecting all this data and doing it in a timely and efficient fashion. I think it's going to be really interesting. So just for some of the background, we've talked about some of this in this arena beforehand, but I know not maybe everybody is familiar with kind of HO. So just very briefly, a few words on it. So basically, heterotopic ossification is where you grow bone in abnormal places or places you don't normally have it, like muscle and soft tissues. And it's fairly common after acetabular surgery, with incidence rates anywhere up to 90%, depending on the study you read. And unfortunately, with these more severe cases, like this example on the right, you can have bone that actually extends from the pelvis and it goes all the way to the femur. And that hip's not going to move very well, and that patient's going to have pain, and they're not going to be very happy with you. We can go and cut that bone out, do a separate surgery, but that bone then tends to come back. We don't really know why. And that surgery also has a lot of complications. It's a big bloody surgery with various complications that we try to avoid doing to begin with. And there's a few different modalities that we can do to try to prevent this abnormal bone from growing, but really there's no large multi-center randomized controlled trials telling us what the best modality is. And as a result, protocols vary not only from center to center, but from surgeon to surgeon. And the three techniques that we really talk about are one, a debridement of the gluteus minimus muscle. So one of the abductor muscles, which can often be injured in these fractures. And we think that some of that devitalized muscle might be an impetus for growing this abnormal bone. So we can either cut that out, but there's no formal prophylaxis other than the surgery and some debridement that is given. Indomethacin therapy, so we can give pills. So people will typically take them 3 times a day for 6 weeks. And the issues with indomethacin are GI side effects, then also compliance, which we sort of talked about before, but you can prescribe somebody a pill for 3 times a day for 6 weeks, where the chances they take that are very small. And then XRT therapy. So within 24 hours before surgery or within 72 hours after surgery, you can give them a single dose of radiation to that surgical site. And the data in the total hip literature is very good for XRT, and there's certainly some literature in the trauma world as well that it works. But the drawbacks to XRT is, one, is expensive, two, resource utilization. So not all the centers have access to this. And then there are more rare side effects like radiation-induced sarcoma and infertility, which are exceedingly rare and kind of case reportable, but at the same time the risk isn't zero. And so we're trying to sort of attack this question from a multifaceted approach. And these studies are all sort of ongoing in multiple stages as far as done and submitted to, our RCT, which we just started rolling this week. But the prepared data we use to really talk about national trends and outcomes. And our aims were, one, to talk about national prophylaxis patterns, because this really hasn't been done on this level in pretty much 2 decades. The last paper kind of on this is in 2001. So we just want to talk about, in 2020, 2021, what are people doing for HO prophylaxis across the country? And then we also wanted to look at radiographic outcomes and see if there's any difference in HO outcomes between the different treatment groups. So we took all the patients that were in the closed prepare group with type 62 fractures, so acetabular fractures, and those that were, at the higher risk of developing HO, so patients that underwent combined anterior and posterior extensile exposures. And then we excluded all patients with either isolated anterior exposures or if they had acute total hip performed at the index procedure. Our intervention group was XRT or indomethacin, and we compared these patients to those who had no formal prophylaxis. And then our outcomes were radiographic HO, so overall HO defined by the Brooker classification, so classes 1 through 4 for overall HO, and then severe HO, so the classes 3s and 4s, sort of like that first example we showed where you got bone extending all the way from the pelvis to the hip. And then we used their last follow-up radiographs. So as sort of mentioned in the beginning, we have almost all the data. There's like literally only 1 or 2 centers just with some IRB delays, and it's only a handful of patients, which won't really change sort of the results here. But sort of what we have so far is 383 patients that were screened, 112 were excluded because they were either an isolated anterior approach or had an acute total hip. 15 patients were completely lost to follow-up, and then 35 patients had some x-rays, but they were greater than or less than 6 weeks from surgery. So that left us with 221 patients that were available for the analysis. And when we look by patient, so what were the most popular trends for prophylaxis? Over half of them got no formal prophylaxis and either got, a gluteus minimus debridement or not, but no indomethacin and no XRT. The least common was indomethacin at 11% and then XRT 35%. So this is by patient. We wanted to do sort of separate this out a little differently because that XRT number is probably a little inflated, not the least of which is because shock contributed the greatest number of patients, but then also routinely does XRT. So if we actually look at it by center and say, based on the center, what is the highest proportion of prophylaxis within that center, we see that that number for XRT actually comes down because out of the 19 centers, there's really only 3 centers that are predominantly doing XRT. And the vast majority of them are actually doing no formal prophylaxis. The numbers don't add to 100 because there's one center that was really split down the middle evenly between no prophylaxis, indomethacin, and XRT. And these results are really interesting compared to, the last study of this kind, which was in 2001. Again, it was sort of a survey study, but OTA, trauma surgeons, about 250 or so of them. So a similar number. And you could see that at that time, almost 90% of them were given formal prophylaxis compared to the complete opposite in this group. And then of those who were given prophylaxis, over a third of them were given more than one type, indomethacin and XRT. And then the most common type of prophylaxis they were given, again, was indomethacin. So 80% of them given indomethacin compared to that being 0% of the majority in this study here. So really interesting. So what accounts for the difference? Hard to know. Maybe some increased information about maybe that gluteus minimus is the bad actor and we should be debriding that more. Certainly, Dr. Rout has published a lot about that and has maybe had some people buying into that. And then there's also been a few single center RCTs showing that maybe indomethacin isn't as good as we think it is. So, perhaps. And then looking at HO formation. So overall HO for the entire series was about 24%. And then we look at it of the 3 different subgroups. So indomethacin, XRT, 17 and 18%. No prophylaxis group, a little bit higher, almost 30%, but no statistical difference between the groups. However, if we do combine the XRT and the indomethacin group and we say, okay, let's compare patients who had at least something for prophylaxis compared to patients who had nothing for prophylaxis, we do see a significant number between these 2 groups. But then moving on to sort of what we all care about, and that's the severe HO. So that's the Brooker's 3s and 4s. the more clinically significant HO, really no difference between the groups. So indomethacin, 8%, XRT, 8%, no prophylaxis, 9%. And even if you combine the indomethacin XRT, obviously you can tell still there's going to be no difference. So when we look at the more severe forms of HO, we really didn't suss out a difference between these three groups. And this is the DAG diagram that, again, we sort of talked about with some folks, and Lucas and Lee and Roman and everybody were helpful in helping construct this and identifying some of these confounders and these biasing pathways that we wanted to account for that have been previously identified in the literature as being associated with increased incidence of HO. And so we looked at some of these things. And when we look at overall HO, actually head injury, hip dislocation, need for ICU, these sort of things actually weren't significant with developing HO. Fracture type was approaching significance. So elementary fracture just means it's more of a simple pattern. And associated fractures means it's more of a complex pattern. So you can see higher incidence of HO, but it didn't reach significance. Gluteus minimus debridement. Not quite sure what to make of this, to be honest. So those that did get a debridement had a higher rate of HO, which seems sort of counterintuitive because you'd think, you should be cutting out. The whole point is to take out the meniscus so you don't develop HO. So it could be a few things. One is certainly a selection bias, that it's, probably the more severe fractures, the more complicated fractures with greater soft tissue injury that are more likely to develop HO, but those are also the ones you're more likely to do a formal debridement. And then maybe some recall bias is just as far as operative records being entirely accurate, or surgeons, even when we talk directly to surgeons, them trying to remember whether or not they debrided a minimus in, a tab that they did, weeks or months ago. Looking at severe HO and some of these factors, ICU was significant, which is consistent with previous literature. Again, certainly confounding factors with that, but for patients who are admitted to the ICU, they had a higher rate of severe HO, 19 versus 7%. Fracture type, sort of as expected, did reach significance here. So again, if you have a more simple fracture pattern, you're much less likely to develop severe HO compared to the more complicated or more complex associated patterns. And again, this gluteus minimus debridement sort of issue showed up again. If you had a debridement, which maybe is just a surrogate for a worse injury, you are more likely to develop severe HO. So really just from the preliminary look at the data, there's kind of three takeaway points. One, very interestingly, how different prophylaxis patterns have changed over the last 2 decades. And then looking at the differences between no prophylaxis and indomethacin XRT, yeah, it seems like if you give patients something, whether that's XRT or indomethacin, you do reduce overall HO rates, which is sort of consistent with the literature, but it seems like you're really maybe reducing kind of the less severe rates because there was no difference in the Brooker's 3s and 4s. And those are the ones we really care about, which raises the questions whether, it's worth the risks that go along with XRT and indomethacin if you're not really getting significant benefit from developing severe HO. So that's what we have so far. Again, thank you so much to all the centers and being, so awesome and so efficient with collecting all that data and getting it back to us so quickly.
Awesome. Thanks, Adam. Cool. Another cool sort of analysis using the PREPIT data and kind of leveraging our patients and all the centers that participated. Just because we have some patients on the line and everything, I was just going to kind of summarize in plain terms, and Adam, correct me, please step in. Let me know if I'm wrong here. So you basically looked at a handful of acetabular fractures, which are some of the worst fractures around the hip that we take care of. And because these fractures are bad, sometimes patients will grow bone in abnormal locations, usually in the soft tissue or the muscle that's injured around the fracture site. And we have tried a number of means throughout history to prevent that abnormal bone growth. It looks like, however, over the last 20 years, the type of prophylaxis and means that we use to prevent this abnormal bone growth is changing. And that maybe all of these interventions we've been using to prevent bone growth don't actually prevent it any better than just a standard surgical debridement. Is that sort of an accurate summary of everything, Adam?
Yeah, absolutely. That's pretty much what these data would show.
And that people can step in whenever they want if they have questions, burning questions. it looked like you guys controlled for a number of variables, head injury, etc. One thing I didn't see on there, did you account for polytrauma or injury severity score on these patients?
Yeah, we actually did put I didn't put kind of every single thing we had obviously in this PowerPoint. So ISS was if you had there was a higher mean ISS for patients that developed overall HO. Interestingly, it actually wasn't significant for the severe HO group.
Okay. And tell me a little bit about how, I know that you classified these by the Booker criteria, which is essentially from it's 1 to 4, if I remember correctly. And basically 1's the least severe. The higher you get up to 4, it's like basically bone bridging across the joint. How do you know that when you were analyzing these patients that the amount of abnormal bone growth or heterotopic ossification had reached maturity? Meaning, how do I know that somebody that's a Booker 1 or 2, when you analyze the data, couldn't become a Booker 3 or 4?
Yeah, that's a good point. So most of the literature in the trials that have been done on this I guess I could back up. The traditional Brooker classification, if you're going to be a purist, should be done at 6 months. And so I think that's what a lot of the early studies did. And then they sort of realized that actually HO develops and matures far before that. So you typically see it as early as 4 to 6 weeks, and usually it's well matured by 2 months. And so you'd see some of the studies so we use 6 weeks for this because that's what Dr. Rout used in his large series, and it gives us the largest number of patients, quite frankly. Josh Gary used 10 weeks for his cutoff, and Karen Acker used 3 months. So there's a variable sort of number of cutouts, but the chances of it being drastically different in that time frame aren't very high. So I think the older school version of waiting till it was matured, it had sharp cortical margins on X-ray, or you can measure different things in the urine to see, if they're still making bone. Those have sort of gone by the wayside, and we sort of realized that it actually matures much earlier than that.
I got a couple of questions. This is David from the Method Center.
Yeah.
Why did we choose to specifically look at type 62 fractures? Is ossification not a concern in other regions of the body?
Yeah, that's a good point. So it certainly is. I mean, around the elbow is also another common problem where we have it. It's just that acetabular fractures are just one of the worst actors as far as HO is concerned. And it's also one of the places where we're expending all these resources and money doing XRT, where we typically don't do much intervention in the way of elbow or other places that you typically develop HO. So burns patients will get HO, elbow fractures, these things, but we aren't doing a lot of interventions. Whereas HO around the hip and acetabular fractures is so common that we've spent a lot of time and money and effort to try to prevent it from happening in these patients.
Okay, and why did we also limit it to a specific surgical approach? I think we just looked at posterior approaches. Is that right? Why not anterior approaches?
Yeah, so for whatever reason, you can argue some of it might have to do with the fracture pattern and how we approach these things. But when you do an anterior surgical exposure, the patients just don't typically get HO, and a lot of that has to do with the gluteal musculature and where you develop it. So when you do a posterior approach, you're going through those hip abductors. And so whether, and again, it's a sort of a chicken or an egg thing, but there's the trauma of the injury, and then there's the trauma of the surgery, and then there's a lot of other factors that we don't know about. But when you go to the hip from the back, that's when you typically get HO. And so we don't even prophylax people who just have isolated anterior approaches. So that's why they're not really worth looking at.
Awesome, thanks.
I could just add a little sort of clinical vignette to some of this. I think Adam and Lucas have talked about the importance of this question, and you also see that the severe HO isn't that common. I have a few patients in my practice, but I have one in particular that I've seen recently who got horrible heterotopic ossification of the hip. So he's grown bone all the way essentially from the hip joint to his proximal femur. Basically the abductor, the buttock muscle is basically all stone. And so he can't bend his hip, and he comes in to see me and he's miserable. And he says, I can't sleep. I can't lie down flat. I sleep in a chair. I can't walk. Because I can't walk, I can't get to my medical appointments, and he's just falling apart medically. You know, like his surgery, his X-ray, other than the HO, looks great, and he is doing absolutely horrible. And it really obviously saddens me, and he's quite distraught at this point. And so, because the surgery and because that complication is so debilitating, you know, at our hospital, we really spend a lot of time and effort, and we expose people to radiation to try and minimize that, because we believe that it works. And Adam has shown us some preliminary data that suggests maybe it doesn't work, but also he showed us that slide that basically shows, hey, we want to find out what's being done in the Prep-It network. We want to get an understanding of what the data may show within our patients in 2020, 2021. And then if there's something compelling here, this is going to be perhaps another trial that we do to try and answer this question, because, you know, the consequences of this disease when it occurs is so substantial. And I think, again, you know, we're really always trying to show everybody that from this main trial, we're going to ask other questions, we're going to try and learn, and we're going to try and advance care in another region. And I'll always remind you that Prep-It is partially spawned from Mo and Sheila's previous trial called Flow, and we're always trying to learn and take the next piece of information into the next study to advance patient care. So Adam, thanks so much for taking the lead on that. I know Lucas and Carol and a bunch of other people have done other studies that look at sort of what is being done amongst our patients and amongst our surgeons. And again, you know, all the coordinators, thank you for leading these efforts at your local sites, and of course our patients who continue to keep us grounded on what's important in these studies. Lucas, do you have any other? It looks like Jordan's got a question.
Yeah, I was just curious. There was a mention of there still being some outstanding data. As far as the sub-study goes, is there any reason to believe that when that data does come in, that these conclusions could shift at all? Or do you feel like what you presented, Adam, is going to remain consistent?
I think it's going to remain
statistical significance that you touched upon.
Yeah, I think it's going to remain significant. I think there's like 5 patients or something outstanding. Yeah.
I have 2 questions left. Sorry, I like to ask questions. Let me ask you one quick one, Adam. What do you think changed between 2020 and 2021 that turned people off of indomethacin so much?
Yeah, I don't know. I think there's a lot of bad side effects with indomethacin, and I think people don't like it. And I also think that, Dr. Karenecker did a good job in his RCT, like testing people for indomethacin levels and showing that people don't take it, right? So you're giving somebody a drug that has bad side effects that people aren't going to take anyway. And then we have 2, at least, well, they're smaller single center, but 2 RCTs in the MATA and the Karenecker study that showed it's no better than placebo either. So I think there's a good argument that there's really no evidence that works, and that you're just putting your patient at risk of having a complication. But people still do it, so I don't know. So people are still giving it, and I feel like some people, like Dr. Slobodin said, are so afraid, of their patient getting HO, and it's typically right, like a patient who's in the intensive care unit, who has a really bad injury, a really bad fracture. You think you do a really nice reconstruction, they got a good looking hip joint. The only thing that's really going to ruin that is if that patient gets HO, maybe you don't have XRT or don't believe in XRT and you want to give them something. I feel like maybe those are the patients that are typically getting indomethacin.
Yeah, I tend to agree that you have the RCTs that show the indomethacin doesn't work. That probably changed some people's minds. And then I think it was the Saji paper in 2014 that showed a higher non-union rate on the femoral shaft fractures in patients that get indomethacin. And so I think that maybe a lot of these patients are polytraumas, and maybe that's driven some people away from using it as well.
Yeah.
And then last question, I'm going to tie the 2 talks together if Nathan's still on the line. Nathan, it sounds like Adam just presented a bunch of data where surgeons have strong preference. Like Slobodin's got a strong preference to use XRT because he's got some patients that have had debilitating complications from heterotopic ossification. I have a strong preference to not do XRT or NSAIDs or indomethacin because of side effects and cost to the system and patient convenience and all of those things. Would this be something that would be amenable to instrumental variable analysis?
I think it is. Yeah, I agree with you, Lucas. I think if we keep looking for them, I think we'll find a number of things that meet a lot of these assumptions that we have for instrumental variables. So as you mentioned, there are a lot of strong preferences within the surgical community, and I think we can use those to our advantage for these secondary data analysis.
Lucas, can I ask you a question? If you don't give either, by the way, do you routinely debride gluteus minimus on every single case, or only if it looks speed up?
If I'm making a posterior approach, so either Gibson or a Koch or Langenbeck approach, I will debride all of the muscle that appears injured. I do not routinely take a large swath of the gluteus minimus, but I will take as much as I grossly can see with my eyes is damaged. So if it's contused or bruised or torn up in some cases, I'll excise all of that. I'm also very aggressive about excising the superior and inferior gemelli muscle bellies as well. So there are some people, I think, that routinely just take a big chunk of the gluteus minimus for exposure purposes and getting their plate down. I won't routinely take it unless I think it's injured, and then no prophylaxis. And that sort of stands for all the 4 trauma surgeons that are at my institution currently. I think that's everybody has a similar approach to that problem.
If I could just bring in our patients for one simple question. The answer may not be simple. You may not have the answer right on the spot here, but hearing my story about my patient with HO, then hearing the fact that our treatment currently at Shock Trauma is to give you a single dose of radiation to your hip, and then hearing Adam's initial assessment that may not actually make a big difference for the severe HO, but it probably does make a difference for the less severe HO. What are your initial thoughts? And the reason I ask, if you were in the situation, would you want to have radiation or not? And I bring this up because when we start to do these trials and start to think about these trials very, very early, this is the very first step we take as we come to our patient partners and start to ask these questions just to hear what comes to mind right off the bat when I ask. And so, Jana, I'll call on you, but I plan on calling on Deb and Jeff after.
Oh, I'll start by saying that breaks my heart to hear about that of your gentleman who's in that much pain and life debilitating for him. I think this is a perfect time to start a new research. So if you don't have the answers, how can we find that answer? So I think I've shared along the way, for me, I trusted your opinion. So when you gave me suggestions, or my husband or whoever was there when you were talking through whatever was the next treatment for me, I trusted your level of expertise. So I think you probably have a lot of patients that are in that situation. They're going to trust the surgeon knows the best answer. So if you don't have that best answer, then perhaps that's an opportunity to dig further and find it, if it's possible.
Yeah. Deb, what are your thoughts? Would you want XRT? You're not sure, on the fence, need more information?
I would have to think about it at the time, and given the information that was presented to me, because I would at the time look at all different factors in terms of possible outcomes, such as for me, when I had my accident, in terms of fertility issues involved.
Yeah, that's definitely one of the things that they talk about when they ask.
Yeah, not that you were my surgeon. I, like Jana, would have most likely followed what my surgeon suggested.
And if I can add one more thing, I probably would have done, or I probably would do anything to get my life somewhat back to normal. So if the surgeon is telling me this is going to help you versus your gentleman who's coming in now and can't sleep, can't lay down, can't walk, can't sit, struggling with all those pieces, I want my life back to normal as much as possible. So if radiation is the answer to that, give me the radiation. I'll take the long-term effects because right now I can't do anything anyway.
I really think it comes down to as a patient, I'm trying to get the best outcome, whether it's buying a lottery ticket and hitting the 1 in a billion chance, or having faith in the surgeon that knows more than I do. I'm dipping my feet into a pool that I don't know much about, so I'm going to take the expert that is there, what their suggestion is. But I would be willing to take whatever risk to have the best chance at a good outcome.
Yeah, and
I don't
I
know if
think
that makes sense.
no, it always makes sense. And I think Jana framed the question really well too, right? Which is obviously we're going to make the recommendations that we think are best, but sometimes we don't always have all the information to be certain about that. And so again, I want to commend Adam for taking this project on. And as we get more information, obviously we'll be sharing it across the network. And this may be, another question that we want to take on as a group. Or maybe we'll have enough information just purely from this analysis to sort of answer that question.
Awesome. Well, it brings us close to the 11 o'clock hour. So unless there's any burning questions, I'd like to thank Nathan and Adam for 2 awesome presentations that sparked some debate and got us thinking about kind of our next wave of analysis and another problem that's kind of lingering out there that hopefully we'll have more data on and be able to make better clinical decisions for moving forward. And thanks for another awesome prep rounds for our hour, everyone. Thanks for tuning in and joining and being part of the discussion as we kind of move through this.
Thanks again, everybody. Have a good day.